my lecture. Not only part one, but part two also, I referred to Dr. Volpe's text. All the references that I'm going to be quoting will be included on the slide. So there's no need to worry about, where a fact is coming from or where the evidence is coming from. Also, the problem with this topic is that sample sizes for most studies are very small, especially prospective trials and studies that are being done mostly are on less than even 100 patients. So we have a massive problem in front of us when it comes to quoting adequate clinical evidence for practices that we have in this aspect of neonatology. Last time I went over the dealing with how we are going to deal with the problem, and these are the same slides. All I did was I flipped the protocol and first of all, looking for the red flags that prompt us towards the problem. And also, at this time, since we are dealing with the management and the diagnosis of brain injury in the preterm neonate, I think the red flags are extremely, extremely important that we pay attention to them. Those of us who are in training, we know that we have a system of learning by doing, which is a very difficult system when it comes to a real life patient. And then moving towards plausible solutions, and I will go over a series of possible interventions that are being adopted in lieu of premature brain injury. So basically, the objectives of the session remain the same. The first objective was to correlate patterns of neurologic deficit with timing of insult, and that was covered in the first session. Then the second objective is to develop an organized approach towards recognition and management. So those of you who are watching the lecture, if you're working in a neonatal unit in US, in UK, in Pakistan, if it is a neonatal unit, which is at least a level 2 neonatal unit, which means it's not a well baby nursery, but it is a neonatal unit. I hope and I expect that you will have on-site ultrasound facility where babies are subjected to a protocol of serial cranial ultrasounds when they are admitted. Now, the Canadian and the Australian networks I think the best recommendations that I could see were from CNN, which is the Canadian Neonatal Network. But a very close contestant to that excellence was the Australian network that are coming to consensus statements on improving neonatal care, especially in prevention of neurodevelopmental injury, neurodevelopmental delay among very premature babies. So this is like, how in every field there are these major challenges. So, in our field of neonatology, I think the most exciting and ongoing challenge remains prevention of disability in the neonate that we save with so much hard work and so much effort. So we need an organized approach, and I feel that we do have an organized approach in the form of serial cranial ultrasounds. At least that much is in place, and that much we do agree. Then, of course, my third objective is to know how to counsel the parents of a preterm neonate. And that is something that is wanting, that is something that needs to be discussed even further beyond the scope of this lecture. And you're welcome to hold separate sessions on that, in which concrete protocols of counseling should be devised and shared according to cultural preferences of where the neonate is born and where the parents are coming from, even religious preferences. So we know that there is a cognitive, behavioral, and attention or socialization deficits in 25 to 50%. And last time I shared Pakistani studies with you that showed more than 50% deficits. So we are lagging behind. If you're listening from Pakistan, we face even a bigger challenge, and we are lower down the hierarchical or the evolutionary ladder that our colleagues in other countries are facing. And by other countries, I mean India and Bangladesh, because literature from those countries is also quoting less incidence and less prevalence of neurodisability compared with Pakistan. So these are all references. I won't go into them. Now we know that it is the main representative, periventricular intraventricular hemorrhage, and periventricular leukomalacia. Last time there was a question whether this is the commonest pattern of injury in premature neonates in Pakistan. And I reviewed the literature again, and PVL is quoted as the characteristic form of ischemic injury in preterm infants as well. Now, this refers to a coagulative necrosis of the white matter. And we went over the pathophysiology last time. The dorsal white matter in the lateral horn of the lateral ventricle, especially involving the center of the semicircle visual radiation and auditory radiation. There have been advanced brain studies using magnetic resonance imaging, and there is a special protocol that they run for premature neonates. Now, this may be, and this is even in advanced setups like the Canadian Neonatal Network, the Australian network, making the availability of MRI and the feasibility of doing an MRI on a very sick neonate is still beyond a lot of resources. However, we know that 50 to 80% of extreme and very preterm neonates have diffuse white matter abnormalities, which correspond to the minimum grade of severity. I've given the reference there. And this is a large cohort that was done to study the brain injuries. So in fact, the diffuse component of white matter injury, which is very difficult to detect with ultrasound, I want to point out right at the outset, the diffuse component of white matter injury is the most common abnormality observed in contemporary cohorts. So this is something which is very hard to detect by ultrasound, and this is something that gives rise to further complex problems like learning disabilities, vision problems, attitudinal and behavioral deficits in these children. It is not just, the presence of blood around the brain and the periventricular leukomalacia seen on ultrasound, although that is something that we see commonly in premature neonates. Now, this is one of the studies that I was very, very impressed with and this was the largest study that I saw. 193 preterm babies were subjected to study, and it was seen that they were classified as having a moderate to severe motor impairment with 27%. And 50% of them were mild to severe motor impairment. And white matter abnormality were predictive of motor impairment in very preterm babies, with mild versus no white matter abnormality increasing. Now, I won't go over the numbers, but I've quoted this study here because neonatal white matter abnormality was correlated with motor impairment in very preterm babies at 5 years of age. So this is one of the largest studies, and I think this is one of the longest studies that I have seen in these babies, and they have done an excellent job. The stats and everything, I've left the study here for you. You can discuss it in your journal clubs. To me, it was a very nicely done study and very convincing statistics. Okay, so now that we know the nature of the beast and we know that, the conventional tools that we have, like ultrasound that we run in a protocol, and we do serial cranial ultrasound on these babies to be able to predict the presence of intraventricular hemorrhage, periventricular leukomalacia, maybe to guide us in what more is needed for for the future of the baby, I will go over some aspects of management, if any. I mean, there are very limited avenues available. For now, what we can rely on is good obstetric and neonatal care. And that is a very general term. That is like a blanket term to say that, yeah, if the system is good, everything will work out. But that is true. If the system is good, things things are expected to work better than what they are at this time. So the primary prevention of brain injury in the premature neonate, the primary prevention occurs at the level of the OB-GYN colleagues. I don't know if there are any listening here. They are most welcome. And last time, even some people mentioned, are there any obstetricians? Are there any gynae colleagues? So I'm not sure if there are any gynae colleagues, but if there are, welcome. And I hope that we can form a working relationship among ourselves, because close intradepartmental cooperation, intradepartmental, a very good system of sign in and sign out, and a very good system of follow up of the patients, and a good system of high risk motherhood, then strict record keeping of cases of preterm labor and diligent follow up of investigations. The cultures that we send on these mothers, the inflammatory markers that we send on them, and so many other things. If we have good record keeping and we can review these from time to time, we can come up with better preventive strategies. Regular morbidity and mortality meetings that are dedicated to cases of preterm labor. This is something that I tried. I tried to establish this, and I did have some success in Lady Reading Hospital. I have to give credit to the obstetrics and gynae department of Lady Reading Hospital, which is a massive, massive service. I don't know, I think it is 300 or 400 beds. I mean, it is a massive, sorry, it is 100 and some beds, but they have a massive number of deliveries. I mean, I have yet to see a bigger baby factory than Lady Reading Obstetrics and Gynae Department. They have a gynae building, so they have their own building. And they were very cooperative, and we did succeed in developing this interdepartmental collaboration and MDTs to discuss these high-risk cases. Now, primary prevention at the level of pediatrics and neonatology. Of course, interdepartmental meetings to review cases of preterm moms and babies between obstetrics and peds, combined obstetric clinics for high-risk cases. I don't know if it is happening in Indus or Aga Khan, but I know that I was exposed to these clinics during my fellowships, during my residency, and there were geneticists and pathologists, and everybody would sit together and discuss, the zebras, the unusual cases. Then regular sessions in emergency care for the newborn, for medics and nursing staff that are working around these mothers and babies. It cannot be overstressed. It cannot be overemphasized. And I would request this platform where maybe, many senior people are sitting, to please mandate this at the level of district hospitals, that the staff and doctors are trained in at least the essential newborn care. Not only the teaching hospitals, but wherever babies are happening, we hope that they can be stabilized in a safe and judicious and evidence-based way. Of course, the joint effort is the solution. Like I said, I am a solution-based learning sort of person, and I get interested in a problem only when I realize that I can develop and I can have a tangible solution for the problem. So regular interdepartmental meetings, regular sessions to teach and update skills, then regular morbidity and mortality reviews, and of course, the dissemination of information to public. And this will only come after the first 3 steps are adequately and satisfactorily taken care of. This information can then be disseminated to public, to to help improve maternal nutrition, maternal condition, to help improve the knowledge about the onset of a preterm labor and hope for better outcomes. Okay, so this is a study from Archives of Child, Fetal, Neonatal, part of the Archives of Diseases in Children. The most common brain injury types in the preterm neonate detected by the cranial ultrasound include blood in the germinal matrix or the lateral ventricles, and all of us who have worked in units are familiar with this image. You put the probe on the fontanelle and you see the bad news. You know, I mean, I had an ultrasound in my unit. Although I tried a lot, I did not have a baby probe, but we could detect this with the help of a radiologist. Um, then a hemorrhagic or ischemic lesion in the cerebral white matter, post-hemorrhagic ventricular dilatation without hemorrhage, posterior fossa hemorrhage, focal infarct, subdural hematoma, and cerebral venous sinus thrombosis. So this is a multitude of problems that you can detect with a very modest and not a very pricey system of having an ultrasound machine and a baby probe in your unit. And it is very easy actually to get trained. And that, I hope that our trainees also are able to perform this examination on babies and document it in the baby's records. Like I said, out of the primary prevention, the biggest tool that we have is for secondary prevention, and screening is the cranial ultrasound. Like I said, it is, MRI remains impractical. And this study is not coming from, a third world country or a developing country. This is from a developed country. And, studies from Italy, studies from the Canadian Neonatal Network, from the Australian, from American Academy of Pediatrics. We know that MRI is very good, and, MRI can detect so much more, and it can predict so much more disability. It remains impractical as a routine screening tool. I will go over the differences in sensitivity and specificity of cranial ultrasound and MRI, but we should be very cognizant of the fact that it is impractical. And then, sequential cranial ultrasound during the neonatal period can reliably identify many brain abnormalities, enabling the prediction of abnormal neurodevelopmental outcomes at 1 to 3 years of postnatal age. So it remains a screening tool, a universal screening tool to diagnose and then also to follow up, to monitor brain injury in the preterm neonate. Okay, so once again, this is a local article. This is a Pakistani article from 2013. And they went, and it's quite well done. I was very happy to see this, the protocol that they followed. It doesn't describe the significance of ultrasound, but it shows you a very nice follow-up that they did for these babies. It was a decent number of babies, and they detected IVH. Now, the 21% of the babies developed, 31%. Yeah, 31% of the babies developed intraventricular hemorrhage in the first 24 hours, and 21% developed after 48 hours. So these statistics, comparing them to international statistics, these are like 52% of the babies, and these are quite premature babies. These are very alarming. These are very alarming. Now, the study is coming from a good hospital, and they've done a very good job. It came out in 2013, so it is 10 years old. I would recommend a follow-up if any one of you is watching here. Maybe you're senior neonatologist by now. So I would suggest a follow-up on this design. It's a very, very large number. It's an alarming number. And they use cranial ultrasound to follow up to diagnose and to follow up on these babies. Now, this is a study that I have included here, and this is something that it's like on my wish list for, it came out in 2020. And this is from, I think, the Canadian or the Australian neonatal, Canadian, sorry, it says the CNN. So this is the Canadian Neonatal Network. They have a big database. We don't have a database in Pakistan. I'm not sure about other countries like UAE and other countries, whether they have good databases. But they do something which is called evidence-based practice for improving quality, EPIQ program. And the goal is to decrease the incidence of acute brain injury using quality improvement methodology. So this is a very, like how in UK, there is a lot of stress on doing audits. And in US, there is a big push towards doing trials and then generating evidence. And then, we, the SARC countries, the SARC people sort of fall in between. We don't know, but we follow what is coming to us because it's very hard for us to generate original evidence. If we can implement the EPIC type of studies in our units, and I have tried to do that with my initiative, which is called SPIRE. We are working on pediatric myocarditis, so that is not included in neonatology, but we will be doing SPIRE neonatal studies in due time, inshallah. But, doing research for quality improvement is a very beautiful concept. It's not expensive, it's not hard. It just makes the people in that unit more vigilant to improve towards improving outcomes. It's not a bias. They know that they are in a study protocol and they try to improve the outcomes because that is the desired outcome of the study. That is why I've included it here, and I hope that the young ones who are watching here will go over the study protocol. I've given a reference here. Okay, so then comparison of brain MRI, and there is a specific protocol which is used for premature neonatal brains, which is the SWI, the susceptibility weighted imaging. I don't want to go into the details. Honestly, I read it for the first time myself, but you can read more. The main limitations of this initiative are essentially those of the imaging tool used. It is known that cranial ultrasound is less sensitive than MRI for detection of predominantly small and subtle forms of neonatal brain injury, and those located in the posterior fossa and periphery of the brain. So this is something that all of us need to keep in mind, that these are the limitations of the main tool that we are using. And this is where we can miss injuries. If a baby is behaving like he or she has an injury, but the ultrasound keeps coming up normal, it is now suggested to go for a cranial MRI. I don't know if susceptibility weighted imaging is being done in Pakistan. I haven't seen it. If it is being done in UAE, I don't know. Colleagues are welcome to comment. I know it is being done in US, and that too in selected centers, and not all the centers where it is where it can be done. Okay. Susceptibility weighted imaging is an advanced MRI sequence that is being increasingly used. It exploits the T2 properties of the substance, which enhances the visualization of paramagnetic blood products, which is deoxyhemoglobin, intracellular methemoglobin, and hemosiderin. Now, presence of iron, it's amazing how to think that there is an increased amount of iron present in the areas that have undergone an injury where bleeding has occurred, and it uses that quality to detect the presence of a lesion in the neonatal brain. So grade 2 germinal matrix hemorrhage I'm just reading from the results of this study. The important parts I've included here from the results. So grade 2 germinal matrix hemorrhage was the most common germinal matrix hemorrhage detected on susceptibility weighted imaging, and at 87.5%, which was, oh, now this, the size of the study was just 24 neonates. But like I said, it is very hard to generate evidence with large number of neonates in the time allowed to do a study or to, publish a paper. So these were actually, they were not 24 babies, they were 12 babies, and they divided them into hemispheres, and they said that these are 24 hemispheres. It was noted on ultrasound only in 33.3%. So same babies, 87% detection on the susceptibility weighted imaging, and ultrasound is 33. Detection of grade 2 germinal matrix hemorrhage using head ultrasound, conventional MRI. Head ultrasound had the lowest sensitivity, 0, while T2 had the highest sensitivity, 100%. Excellent specificity in detecting grade 2 germinal matrix hemorrhage specificity was excellent. So you can rule out a germinal matrix hemorrhage with a cranial ultrasound. Of all the 24 hemispheres, grade 3 germinal matrix hemorrhage was depicted in 9 hemispheres, and on head ultrasound in 10 hemispheres. Grade 3 GMH was also readily detected with all modalities. So 100% sensitivity and 93 to 100% specificity. These are, I can only show you the arrows, honestly. I cannot read an MRI for you, especially this is beyond the scope of this lecture. But a 6-day-old, okay. I think I moved further ahead. 6-day-old, X34-week male neonate with intraaxial hemorrhage. The image is axial T1 weighted, which is the first one. The first is a CT, which shows an intraaxial hemorrhage. Axial T1 weighted is B, and C is the flare attenuated inversion recovery. And the arrow is showing the same lesion. So I included it here. Hemorrhage is expected to be better depicted by T2 than other conventional magnetic resonance imaging. This is to just drive the point home that even with MRI, the selection of the modality will depend. It is fruitful to have a good neuroradiologist, which is again a rare entity in Pakistan at least. But in other countries, it is advisable to seek the advice of a neuroradiologist before deciding to go for neonatal cranial MRI. Now, this is a comparison between ultrasound, which is A, and a susceptibility weighted image on the B slide. 5-day-old X34-week male with perinatal depression, baby went through a hard time being born. Axial susceptibility weighted imaging shows multiple microbleeds, which are shown by the arrows in the cerebellum that were undetected by the ultrasound. And as we know that the periphery of the brain and posterior fossa are very difficult areas to catch on cranial ultrasound. Now, this is a slide from the previous lecture. The prevention strategies, as we go into the treatment, now the secondary management, and then of course the tertiary or the therapeutic management. First and foremost are the prevention strategies, which is avoidance of cerebral ischemia by detection of neonates with impaired cerebrovascular autoregulation. Free radical scavengers and this was a question last time, whether, free radical scavengers are being used actually. And, there are agents that are being used experimentally. I'm not going to say that they are recommended in the recommended protocols, but there are agents being used experimentally in the hope of improving outcomes for these neonates. Then maternal antibiotics or anti-cytokine agents to prevent toxicity from maternal or fetal infection. And although we do not have a lot of studies, a lot of evidence from Pakistan, I think this is one strategy that has the greatest promise in prevention of neonatal brain injury in premature babies in Pakistan. We need to avoid all the factors. I've discussed this slide in my last lecture. Since we know the pathogenesis, it is easy to guess what preventive strategies we can adopt to prevent brain injury in the premature neonate. Okay. Now, there was a question last time whether vitamin E or vitamin C or agents like GABA receptor agents, interleukins, whether they are actually being used in protocols. Now, this is this is Abdul Razak. This is a latest systematic review and meta-analysis that came out in the JAMA network. And this is from April of 2023. And this is the conclusion of the study. The results of this study suggest that a few interventions, including antenatal corticosteroids, and last time there was a question whether actually, no, my slide was about glucocorticoids. So antenatal corticosteroids and indomethacin prophylaxis were associated with reduction in the IVH risk, moderate certainty literature. Then volume-targeted ventilation, early erythropoiesis stimulating agents. So there was a question again about EPO, and there is a suggestion that it has a role to play. Then prophylactic ethamsalate as an anti-inflammatory agent were associated with reduction in IVH risk. Again, low certainty literature in preterm neonates. However, clinicians should carefully consider all of the critical factors that may affect applicability in these interventions, including certainty of evidence before applying them to clinical practice. So and I'm going to go over certain therapeutic modalities after this slide, but it is left to the discretion of the treating physician and his or her knowledge about the available evidence to decide whether a certain modality should be applied to a neonate or not. There was a question last time about KMC, the kangaroo mother care. The only study that I could find that I was convinced with is a study out of Italy. And all it did was to measure the impact of kangaroo mother care on cerebral blood flow of preterm babies, and they only measured the blood flow in the middle cerebral artery. So it was a very nicely controlled study. People who were doing it, it was not operator dependent. It was just one artery they were testing. They were looking at the change in the blood flow before and after provision of kangaroo mother care. And their conclusion was that kangaroo mother care improves cerebral blood flow. Thus, it might influence the structure and promote the development of premature infants' brain. It's all suggestions, and they are good suggestions. However, I could not find any, robust evidence, but there's nothing wrong with kangaroo mother care, so it is recommended. Then the next, I think, 2 or 3 slides are only about experimental therapies that are being adopted. There are no direct report of ferroptosis. Ferroptosis is a process of apoptosis, which is a programmed cell death or cell suicide based on the accumulation of iron and its metabolites because of bleeding into the brain parenchyma. So there are no direct reports of ferroptosis in neonatal brain injury. There is evidence to suggest that ferroptosis should be more prone to occur in the neonatal brain. The problem is to mimic periventricular leukomalacia in vitro, cultured oligodendrocytes, showed depleted GSH and cell death. Considering the emerging evidence of ferroptosis should be investigated further in models of neonatal brain injury. These are all recommendations and they are all in vitro. I have included them here because this is something that is up and coming. It is coming. This paper is from 2014. I'm sure further advances have been made, and the role of EPO and the role of agents that block damage done by free iron radicals is coming, and it is going to be a major player in premature brain injury. Then and administration of antioxidants, each step in the oxidative injury has become a potential target. So like so many, if I don't know how many of you are familiar with cancer management and cancer chemotherapy and identifying the targets for the cellular targets for the role of chemotherapeutic agents. But again, the cascade of oxidative injury has so many different steps that can become potential targets for neuroprotective intervention. The administration of antioxidants for suspected or proven brain injury is still not accepted for clinical use due to uncertain beneficial effects. But the challenge for the future is the early identification of high risk babies to target a safe and non toxic antioxidant therapy in combination with standard therapies to prevent brain injury and long term neurodevelopmental outcome. So again, these are experimental strategies. Last but not the least is the role of mesenchymal stem cells. This is extremely, extremely experimental. The paper is from 2019, but there is a hope of introducing stem cells into the neonate somehow, and hope for recovery of an injury that has already occurred. These are the papers that I presented last time. These are papers out of Pakistan, and I've left them in this lecture also for anybody who wants to review the available evidence from Pakistan, which is rudimentary to say the least. There's a lot that needs to be done. I think that's basically it. Thank you for your patience, attention, and dedication. If there are any questions, I've left a good 10 minutes, I think 10 or 15 minutes for discussion and questions this time. Thank you.
Thank you very much, Madam. Thank you so much once again. Any question from participant? Any questions, sir? Sir Junaid?
Thank you, Dr. Afshan. But I think if you don't mind, I can just tell you that you focus on mainly on the MRI and all those things. If you can add how to prevent the IVH for our fellows and for the for the frontliner, is more important. For example, the steroids you talk about. For example, the article by Naveed is on our group also. I think he joined today or not, but it is showed about indomethacin prophylaxis. We all know about that the indomethacin prophylaxis we do, but nobody is doing it. But there are certain other, it's called the IVH prevention bundle. If you elaborate on that, that is much more easy, because in resource limited countries, it helps very much to reduce the IVH. That's because see, the MRI is not available everywhere in Pakistan. So MRI is out of the ultrasound. Yes. So ultrasound is a great modality for the IVH to, do it. But once the injury occurred, then it is very few management, as you rightly said about that.
The IVH prevention bundle, I have yet to see it in the literature, but you can elaborate. I mean, as an as an open discussion, I don't know if it is being used as a standard bundle across the NICUs that we are working in. I spoke at length about prevention of IVH even in my first lecture when I described the pathophysiology, the infusion of infusion rate of fluids, the use of pressors, how early we close the PDA, indomethacin, corticosteroids. I think all of that was discussed in the last session. If you are using an IVH prevention bundle, I mean, you're welcome to elaborate on any specific points that
Yeah,
all the units should be following.
sure. The IVF,
Junaid, inshallah, I will be doing in my talk, which is the last one. I'll be talking
that's
about
very good.
neuroprotection bundle. So don't worry.
Yeah. So that's very good, sir, that you are elaborating. The other thing, we have to mention about the hemodynamics other than PDA to maintain the hemodynamics and to limit the use of inotropes in the
Yes.
baby, unless until it is needed, very much needed due to some reason. So the inotropes is also directly proportional to the IVH. So this is another thing which we can look into that, and then
Yeah.
managing the blood pressure and the perfusion other than PDA I'm talking about. The other thing is that we should talk about the effect of the carbon dioxide on the cerebral autoregulation, which can again affect the IVH rate of occurrence. Somebody is talking, I don't know who is talking, but anyway. So anyway, these are a few things. Other than that, we will, as Professor Huff said, that we are talking about. The other thing we should emphasize on magnesium sulfate, the antenatal magnesium sulfate. Their use can prevent the IVH in the newborns. There is one study which I went through is vitamin D study. That vitamin D level is somehow is also related to the IVH. The stem cells is still the part, but there are a lot of debate and lot of things on the delayed cord clamping. This is the new thing that we should be discuss in these type of talks, especially with the neuro effect of the delayed cord clamping, how it is affecting and how it preventing the IVH. So I think these are the few things which we can do without any resources, without any equipment, without any, just barely to take care, as you rightly said, that about the intensive care about that. So these are few points I just have to mention about that. This thing. The basic thing is you also said about reduction of the about the PIVH or the post intraventricular hemorrhage. It's about the delivery room stabilization. We have to emphasize on that people who are attending the delivery, they should know and they should be well trained. What is the effect of mechanical ventilation? What is the effect of hypercarbia, hypoxemia, acidosis? All those things are much more, valuable in this thing. Even the sectioning, in the Cochrane, if I remember correctly, in 2016, they mentioned about the sectioning, that if the baby needs sectioning, you do the sectioning. If the baby don't need it, because there are certain things called routine nursing care, and the nurses are doing sectioning. Babies are sleeping very well, nothing, but their routine nurses care times happen every 3-4 hours and they were sectioning, and it can affect the cerebral blood flow, which can lead to the IVH. Mechanical ventilation in itself, a lot of big thing, but we will, I mean, it's a lot of topic. Then one more important thing, I think Professor Haq will talk about it, inshallah, is about the RBC transfusion. We are overusing RBCs, or we are over transfusing RBCs, or we are under transfusing RBCs. I don't know. But the thing is that the effect of this RBC transfusions are is the negative effect on the brain perfusion and the and lead to the IVH cause. So that's all I think from me, that those who are listening, and then inshallah we will discuss after the Professor Haq talk. Regarding the bundle, we publish it. We will discuss after Professor Haq talk that what are the different components, what we used to, or what we are implementing in our NICU. Let's see what he will talk about it. But thank you, Afshan. Thank you very much.
Thank you very much,
Thank
sir.
you. Thank
From
you.
Professor Khalid. Sir, any comment from your side?
No, I think that's wonderful. Thank you very much. I think my talk is going to be on functional anomalies with in neonatal brain development and the effect we have on as neonatologists on the brain. And in that, I will include the neonatal brain care bundle and RBC transfusion and its effects. So I will just be wrapping up the neurology section. My talk is at the last, so I'm glad that I've been listening to all this. Thank you very much, Ashra. It's very good. Thank you.
Thank you.
Thank you very much, madam, once again for a wonderful talk. And thank you so much, Professor Khalid Haq and Sir Junaid Mohib Khan. Sir, our next session will be on the point of care ultrasound focus in newborns by Dr. Naveed Mandurani. So next week, inshallah, once again, we will do the same session on same day and same time. So till then,
Inshallah.
Thank you
so much.